Dr. Natan Zundel is coming up. He is a professor of surgery at FIU, and if the one is international, then this one's transcontinental. So welcome, Natan, and give us your idea on what operation to choose and for whom.
I hope my wife is not listening, Marina. Thank you, Marina. Thank you, Kevin, for the invitation. Thanks, Aegis. This is my disclosure. So this was a very difficult subject that this guy asked me, because I need to put a lot of mixtures. So it's very difficult to go to all the facts to decide what you should do for this patient. So I only have two questions when I decided which procedure I'm going to do to a patient. The first question is to the patient, and the second question is to myself. So the first question to the patient is, what procedure do you want, and why? You see, the patient come to you, I want a band, I want a sleeve, I want a bypass, and then we start from there. But before I ask, or while I ask, I know many, many things that they are hidden. They are going to show you only a small portion of why they want this procedure. And they are going to show you just a small portion of why they are hiding in the way they behave and the way they eat. And they want usually a simple thing. They are not all convinced that they need the surgery. Some look for aesthetics, some are bring by their parents, some are bring by their wife. And they are convinced that some of them are okay, but they are here. And they're looking usually for an easy solution. But we know this. Some recent studies show that if you ask the patients, do you want a bypass or do you want a band? Most of the patients will want a band. Why? I don't need to explain you why. There are many reasons. When you have a 24-hour center that needs escalator electrical to do fitness, something's very wrong. And the patient believes in this, so we need to be very careful with this. Why the patient love it and why we love it? Because we kill very few patients with the band. Zero mortality in most of the series. So the patient doesn't want to die. Who want to die? So the patient doesn't want to die. So they like less mortality, and they like less morbidity. And if you compare the three procedures, and they are able to find it in the literature, you will see that we kill less patients with the band, some more with the bypass, and VBG and sleeve, we're getting there. So we're going to get the numbers. But the band probably has the lesser mortality and the lesser morbidity. They also, even though they expect 90% of excessive weight loss, some of them, they don't know that you don't get that results. They don't know that if you get a specific procedure, maybe you get it only 41 or 42%, because it's the way we present it to them, and it's the way it's been presented in the literature. So you have to be very careful what they've been thinking before coming to you. They have a neighborhood who did well, they read, they saw an advertising in TV, so this is the best procedure. So you have to be careful why they want what they want. And if you pay attention, then the results are good, but are that good? So we need to ask all these questions. So what I'm going to tell you is related with that, and also with the experience we have. We have close to 4,000 bands with follow-up up to 13 years, and we're getting in the 1,000 sleeve now with follow-up close to 6 years. So I will include my experience, because they ask me how I pick the patients. So I know that the patient not necessarily know that with some of the lesser procedures, they've been telling that it's reversible. You see, I learned this from Scott Chikora because my English is not that good. The band is not reversible. The band is removable. And this is a completely different aspect. You can't remove the band. I remember in the past, when our band fails in 1996, 7, we cut the band and take it out. That was a 10 minutes procedure. So it's very easy to remove. Most of the cases, yes. But if you are going to remove the band and convert it to a bypass or a sleeve that probably Raul is showing later today, that's a different story. Now you're talking 2, 3, 4 hours of surgery, perforations, leaks after surgery. So it's not that easy to revise. It's easy to remove. And that's a completely different aspect. Do they know that you can get slippages? And you can slip it, you can get necrosis of the stomach. So you need to make them aware of what happened with every operation. What about erosions? Yes, erosion has been decreasing. But once you have a foreign body, the erosion can come anytime in your lifetime. Are they aware of that? I was in the band summit a week ago, and I was a little bit concerned, because now we are suggesting here in the US what we suggested outside the US in the past, that if you have an eroded band, you don't necessarily need to remove it. Let me tell you something, this is America. If you don't remove the band, somebody's going to remove your house. If a band is eroded, you better remove this band. We did it outside the US. We wait until the patient was really eroded and we take it by endoscopy. That's an approach that the lawyers will love. So we have to be very careful in proposing what we do. I was also concerned because I hear that now you can remove an eroded band, close the hole, and put another band. I'm not that macho. I wouldn't do that. But some people will do it, so we have to be very careful. What about the sleeve? I was also privileged to be on the sleeve expert consensus last week at the Cleveland Clinic. And I left with a little bit of concern. It was a very good 2 days experience, a lot of experts, but I left with a little concern. What I heard from the band in 1995, I'm hearing now from the sleeve. So the band cured everything then, now the sleeve cured everything. So now you can use the sleeve even from athlete foot. So there is no solution. There is only one solution for this patient, and that is my concern. So we know that the number of sleeves are going to increase. Is approved or is going to be approved pretty soon for most of the insurance companies. You heard Sayid Ikramuddin, that is an expert about all the hormonal action, whatever that you have in the sleeve, make it and not only a restrictive procedure, is something else. There is confusing data, but there is data. Also, from the consensus that hopefully Michel Gagné is going to publish very soon what happened in the third consensus, we know that the results after 5 years are getting good, are compared with some other procedures like the band and the previous VBG are very good, not as close as we like to think that they are with the bypass, but they are good. And we know that they also come with complications. And the guys who came before me, they show you some of the complications. And I've seen them too. And this is from Greg. Greg shared with us this slide when he put all the reoperations, major complications with the band, with the DS, with the bypass, and with the vertical gastroplasty. So nothing that we can do to prevent complications? Yes, there is a lot of things we can do. First one, patient selection. This is some of the long-term complications you get with the sleeve. If I got the sense properly last week, reflux probably will end up the main problem we're going to have after sleeve gastrectomy in a long term. So we have to be very careful how to select our patients. This is a leak that Greg showed you before. This is what we call a small gastropleural fistula. You give some barium to the patient and all the barium go to the left chest. So we have complications and very bad ones. So you say, no, the bypass too many complications, so let's go for the sleeve. That's not completely true. Some of the complications I've seen from the list are worse. So once I know all this, then I ask the next question to myself. Why I should not do what the patient wants? So I ask him what he wants. You want a band? Then I will find a reason not to do what he wants. If I don't find a reason, I will do what he wants. If I find a reason, I won't do what he wants. And if he still wants what he wants, I send it to somebody else who will do what he wants. So then I know some numbers. I know that if I compare the sleeve versus the band in this beautiful paper from the group of Belgium, of Himpens and Cadier, then I know that if you compare them one against the other one, the results of the sleeve in weight loss are much better. I need to know that. That doesn't mean that disqualifies the band. No, but I need to know that. It's not that the band and the sleeve are the same. I need to know this. Second, I know, and Sayid showed us, that with ghrelin and other hormones, we get some effect with the sleeve. We don't get it with the band. At least we get with the sleeve close to the bypass. I'm not sure even that with Sayid data presented in the prospective randomized, it was better for the bypass or for the sleeve, but at least say it's good, it's better than the band. But we also know that if you put together the sleeve versus other traditional procedures, you will have good results. I wouldn't say the best results, but if we want the best result, probably we ended up doing BPD to everybody. Why don't we do BPD to everybody? Because I haven't, with all my respect, Michel, but I haven't found a patient that I hate that much that I will do a BPD. So I don't do it. I will send it to somebody. If I think a patient needs it, I will send it to somebody who does this. But we don't do it, even if it's the best operation. We don't do it because it brings a lot of complication and the quality of life is not that good. So for me, the no indication of the band and the sleeve are more important than anything else. So let's go for some of the topics. Diabetes. Band Summit, Christine Wren defended the position of banding for diabetics. I did the counterpoint, I don't do bandings in diabetics. Why? Because I cannot find the patient that Joe Dixon found to do. Because I don't have this patient with 1 year of diabetes. Basically, you can treat it with diet. So I don't do band in diabetics because our experience with diabetic in band is not good. Do I do sleeve in diabetics? Not today. I'm still doing bypass for diabetic ones because the evidence today, and I think it's enough data to say that the best operation for diabetes today is the gastric bypass. So how do we expect endocrinologists to accept this procedure? If we go to there, we offer 10 different procedures as a metabolic surgery, and we don't have a clue which one is better. If I'm an endocrinologist, I say, you know, when you figure it out, what is good for diabetics, come back to me, and then I will let you do my patients. So we need to be very careful to promote every procedure for diabetes. I'm not saying there is not some evidence that the sleeve is better. If I have a patient, diabetic, that doesn't want a bypass for whatever reason, or has a contraindication for a bypass, I'd rather do a sleeve. But I think the bypass is still the best operation. What about the super obese? You know the experience with sleeve in the super obese. I do sleeve in super obese, always telling them that maybe will be a first step. My experience with banding with the super obese that I don't do anymore, 52% of my super obese patients regain weight in a period of 48 months. So I don't do it anymore unless they accept me when they regain weight, I remove the band and change it to another procedure. So I'd rather do a sleeve on those patients. I'm not going much in hiatal hernia because it will be the next topic, but also in the band summit, George Fielding defend hiatal hernias and banding. I did the counterpoint. I don't do banding in big hiatal hernias. So type 2, 3, 4, I don't do banding, and I don't do sleeves. 2, 3, and 4. In type 1, grade 1, 2, and 3, I don't mind doing a band because you can close the hiatus anteriorly. But grade 4, I still don't do bands because I've seen slippages, I've seen the sleeve go back to the chest, these bronchoperal fistulas, this gastro pericardial fistula that I saw, they were all with hiatal hernias, they got a leak, went to the chest. Is hiatal hernia contraindication? No. But if you read, we review more than 42 papers of Soper, Eubanks, McKernan, guys who's been doing reflux and hiatal hernia repair for years. 18% of recurrence if you don't use a mesh. So now are we going to use meshes to get the 3 or 4%? And we put 2 stitches in the hiatus and we repair it? I think if you're going to put a band or sleeve, you need to repair that anterior. But do we know enough? I think the first time the patient cough or vomit, probably the stitches are gone, but we charge for them, so that is good. Sweet eater, greasers. I don't think neither of both will work. I think those patients need a special treatment that we don't know yet. Hopefully I will die before we find it. Reflux and Barrett's, and this is my next concern, reflux and Barrett's. Any patient who really have a significant reflux is being in PPIs. I don't do sleeves and I don't do bands. I do a gastric bypass because the gastric bypass is the best procedure for Barrett and the best procedure for reflux. How I'm going to do a sleeve gastrectomy in a patient with Barrett, knowing that even a small percentage is going to get cancer, and I don't have now an organ that I can replace the esophagus. So I don't do sleeve for sure. And one of the big problems that we have now with reflux is in our experience from 2% to 22, 23% of patients after sleeve, they're going to get reflux that they didn't have before. Imagine if they have it before. So if it was significant, what is difficult is to define the significant. I don't do it. And then you have these other cases that I will go fast. Children and adolescents, elderlies. We're getting all close there, so I will move it to 75 or 80 for the next slide. Primary bariatric, for a second not bariatric, lower BMI, cirrhotic, transplant, etc. So in children, they have a lot of advantages for the band. But in our experience, some of the kids are very scared of needles. Some of the kids don't comply very well. They don't have very good compliance with us. So even that the bounce out, very attractive to them. This band for sure is not going to be removable. This band is going to be revised. And this is going to be revised 3 or 4 years later. It's going to be changed to a different procedure. Do we want to expose the kid to that? I'm not sure. The concept of non-reversibility of the sleeve concerns a lot of parents because we don't know what's going to happen with the absence of, we expect nothing, but expect or assume is not no. So we don't know, and that's the problem with the sleeve in these populations. So the sleeve does not require adjustment. You don't have a foreign body, but it's non-reversible. Change the configuration of the GI tract for the future of a 10-year-old, 11, 13, 14-year-old. How long is going to work? We don't have a clue. We don't have a clue of midterm. We're getting in the midterm, but we don't have anything about long-term. What about the informed consent for this patient? The FDA just approved the gastric band for lower BMIs. Adolescents have to do on the IRBs in some places, in some not anymore, but not the sleeve. But some people are doing bypasses. So if you ask me, I'd rather do a sleeve than a bypass in an adolescent. But that's my opinion. Varela presented in SORT in 2007 these 2 points that are very important. The morbidity of bariatric operation in adolescents is lower than the adults. However, the mortality is the same. So killing an adolescent or a child is something that maybe doesn't let me sleep for the rest of my life. So there is publication against and in favor of doing banding in kids. There is our experience that we published in Bariatric Times in 2010 that we really need more data because now the pediatric bariatric surgeons starting to doing it. So we're going to hear from them. Maybe we get a better clue for them. What about the 65? I think any procedure you do, the 65 will work. I don't like bypasses in people above 70. Anyone who survived life at the age of 70 didn't need a bypass, doesn't need it now. So we're looking for quality of life, a procedure that allowed them to lose 40 pounds, 50 pounds, and make their life good. Be careful with absorption of vitamins, mineral, and medication. Some of the papers show that it's really not affected, but you have to be careful with that. There is this very nice paper from May in obesity surgery in 2008, 7-year follow-up, patient from 50 to 60 and from 60 to 69. The bariatric procedure was effective for weight loss, but believe it or not, there was a high complication and reoperation rate, but it was even higher in the 50s to 60s than from the 60 and the 69. What does it tell you? Probably that tells you that once you arrive to this age of 60, 69, your morbidity is not that bad, so you don't need nothing that aggressive. But if you are in the 50s or 60s, your complication and your operation rate is higher because your problem is bigger. This single banding age or more than 50, the complication rate was the same as the young patient. That is good. With the sleeve, we don't know much, but the concerns and morbidity and mortality, and if some of these elderly already have some motility problems that we don't know. So if I'm going to do a sleeve in this patient, maybe I will do some motility studies before. I have a patient with gastroparesis, and I'm doing a sleeve, and it ended up in a total gastrectomy. That will be very good for weight loss, but it won't be very good for this patient. As a primary bariatric for second non-bariatric, we're talking some patients that require weight loss, like arthrodesis, abdominal wall hernia. You want them to make a cancer column, some column. Cleveland Clinic is doing a study because the complication rate in this morbidly obese patient for another surgery is very high. So why don't we put a band? Why don't we do a sleeve before doing the operation they need? The abdominal wall hernia, the back problem, the knees replacement. And for those ones, we don't have enough data for those patients, but we know this. I have these 3 publications that I found. One for oncologic procedures. So people have been doing it. Szymanski et al. Published in 2010 in obesity surgery in February that before some complex oncologic procedure, if the patient can wait 2 or 3 months, doing a bariatric procedures will help them with the complication and morbidity after the main surgery, oncological surgery. So maybe we can wait, if we wait for this patient. For transplant, these 2, one cardiac transplant, one kidney transplant, Koshi in American Journal of Kidney Disease in 2008. A lot of patients that need kidneys in this country, I think it's like 30,000, don't go to the list because they're morbidly obese. So morbidly obese is a contraindication, if that is a good word in English. So it's discrimination and contraindication because they get much more complications in the transplant. So they are out of the list, so we need to do something to them. But what to do to them, that's the problem. My concern is foreign body versus absorption. I wouldn't do a bypass in any of these patients. We don't know how the cyclosporin is going to absorb. We don't know the FK506 is going to absorb, so we don't know that. So we need to pay attention to foreign body. Do I want a foreign body in this patient that I'm going to immunosuppress? Probably not. Absorption, side effect of medications versus anatomic changes. I'm thinking a liver transplant patient, I want to do a bypass? No, I need that intestine for my biliary tract. Maybe I do a sleeve. So we need to pay attention to all this before doing transplant. And transplant is going to be a big field for morbidly obese patients, because this is the only country that I've done achalacias in morbidly obese patients. Before coming to the US, all my achalasia patients were 40 kilograms. Here, could be 200. So this is a different, and you have now this patient that needs the surgery. Campsen published, very interesting paper, Obesity Surgery, December 2008, that transplant patients require multiple medications, procedures that include malabsorption, interfere with the bioavailability of these drugs, so don't do it. So anatomy changes, the transplant will be delayed until weight loss is achieved, and contraindication for the company for some, if you read the label of the companies, they say that the medication contraindication for those patients. Cirrhotic patient, I don't go there much, but I say that child A, maybe up to B, you can do something for this patient that will help them with their liver problem. But my concern with the band is a foreign body. My concern with the sleeve is portal hypertension. You want the short gastric are not short anymore. They're huge gastrics. So you have to be very concerned what are you going to change in this patient. Low BMI, I will remove this one. This is my last of this special group, what I call extensive gastrointestinal surgery or inflammatory bowel disease. There's no best operation for this patient than the sleeve. You don't want to bring a loop of bowel to a Crohn patient. You don't want to bring a loop of bowel to ulcerative colitis patient, and you don't want to go and remove adhesions for 3 hours before bringing a loop. So make sure that you talk to the patient and the insurance before taking a patient with previous abdominal surgery to the OR and see if you will be allowed to do a sleeve in spite of doing a bypass. Because once you're there, if you didn't ask the patient or you didn't ask the insurance company, you won't be able to do the surgery. And then you ended up with 5 beautiful incisions and no surgery for this patient. So we really need studies for this. I'm moving, Gert is going to be covered later, but I'm going to say that 39% of the patients after banding develop esophagitis, so reflux and banding, I don't do bandings. I know now that with the sleeve, even I don't remember who's mentioned it last week in the consensus, but people have up to 30% of reflux after the sleeve. So we are studying very much profoundly our patient when they receiving medication. So better patient selection, less weight loss failure, less morbidity, and better result. So in conclusion, the band is safe. It's a removable method of achieving significant and weight loss, less operative risk, quicker recovery. The degree of restriction will vary, depends what the patient needs, but the LSG appears to be, for me, more promising regarding as a restrictive procedure. It's more invasive, but it's associated with a better weight loss. There are studies to require about resolution of comorbidity, especially diabetes, could be used as a first stage for DS. And just to mention in your eyes, some people are pushing a little bit for this suture gastroplasty, that it will be the new boy in town. So I will let you to judge by yourself. We've been doing this for 4 years. It doesn't make me crazy. I use it for secondary obesity. So before your patient jump to surgery and make a big splash with a leak or a complication, I want to show you 2 short videos. Can I click this video? No. Can you run this video for me, please? Click. Yes, thank you. So there is volume.
They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, Anna, and you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through 1 a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
So this first video is the band. The patient don't understand well, and we don't understand well what to do with the patient. The next video, if you can run, and this is the sleeve. Can you run this video for me, please? Thank you very much. So this is the surgeon. This is us. mounting in the sleeve, enjoying the sleeve, you know. We love the sleeve, you know. We don't need to worry for adjustment. You're enjoying the sleeve look beautiful. You feel you're flying, you're surfing, you're the champion. Then the sleeve maybe looks big, but you're still enjoying it, you know. You're a surgeon, so you see this is a beautiful sleeve, you know. Now I'm going to do my last stapler. Do I oversew what I do with this sleeve? And the sleeve forming so beautiful. You will see it, how it shapes. It shapes beautiful. Look how the sleeve is shaping. It doesn't look that good anymore. Now I'm running away from the sleeve. That's not. So that's my concept of the sleeve. You can survive the sleeve if you learn good indication on how to prevent leaks. Thank you very much.
Great. Being from Southern California, you warmed my heart with that.